What's up, everyone, and welcome to episode 3 of USMMA EMS Training Online. I am the Res TO, MIDN Alcorn, and today we'll be going over 2 parts, general approach to patient care and PCR writing. To start, we're going to define pediatrics as a whole, or children. Pediatrics are anyone who's not yet reached the age of 15. And also, we are going to treat pediatrics as anyone who's less than 30 kilograms or 66 pounds. As a general approach, this is as per the protocols. I've highlighted sections that I think are important. Type of response, patient call, mechanism of injury or nature of illness, number of anticipated patients, and additional resources. Survey the scene, make sure it is acceptably safe to do so. Consider any biological and environmental hazards, power lines down, snow, anything to do with that. And the number of actual patients. ALS intercept is always considered, and using the proper PPE. For mass casualty incidents, the fellow officers and I have created preset plans for staging areas, triage centers, and transport areas for Tomb Field, and we're working on doing it for more. So stand by, and we'll have pre-planned out MCI centers. So, this is a general approach to patient care. We have the primary and secondary assessment, events leading to it, history of illnesses, sample, OPQRST, and I also highlighted the bystanders and family members. Interview them because they always, most of the time, I won't say always, have good information on the patient. What happened beforehand, how was the patient acting beforehand, stuff like that. Patient presentation, chief complaint, MOI, NOI. Also look for medical tags. Those will be on the wrist or necklace. So for my 23 years, let's just review. We have primary assessment, airway. Identify if the airway is obstructed or clear. Is it patent? Can it open on its own? Any interventions you need? OPA, NPA, suction. Breathing. We have oxygen therapy. Remember, less than 94%. And dyspnea, we're going to give oxygen. Is it too fast or too slow to sustain life? Is the patient speaking properly or effectively? Circulation, any serious hemorrhaging, which is our bright red arterial spurts of bleeding. Is the pulse present? Is it too slow or too fast to sustain life? Is it regular or irregular? And additionally for that, you're going to look at the skin color, temperature, condition, also serious hemorrhaging, and internal hemorrhaging and shock. So if someone has a hemorrhagic shock, that's going to be, they'll have a cool, pale diaphragmatic, and you'll see maybe some bruising internally, or just presented with a trauma. So just to go back to sample. To review the acronym SAMPLE, that is signs and symptoms. What do you observe? What does the patient tell you? Allergies, we have what are you allergic to? Medications, what medications are you currently taking? Past pertinent medical information, get that information. What kind of history do they have? Last oral intake, when's the last time they ate or drank? What was it? Events leading to this. This is for medical history, sample. And then OPQRST is for pain. We have onset. What was the patient doing before it started? P stands for provocations and palliations, which is fancy words for what makes it better or worse. Quality. Can you describe the pain? Is it sharp, dull, bruising? Typically, have the patient describe it without your bias, but if they need some help finding the words, you can assist them. R stands for region and radiates. Is it stationary or does the pain spread? Remember back to the other video with referred pain. Severity. 1 being no pain at all, 10 being the worst pain you've ever felt in your life. What does the pain feel like? And timing. How long has this condition been going on? And how has it changed since onset? Going over that. We have levels of consciousness, AVCU. So this is your alert and oriented with your 4 questions. Person, place, time, and event. They are responsive to voice. So let's say you say, hey, what's going on? And they open their eyes or they acknowledge you. Responsive to pain, say you put your knuckles on their chest or pinch them on the shoulder. and they respond, or completely unresponsive. They are not moving, not responding at all. We have your Glasgow Coma Scale, their pupils, Cincinnati Stroke Scale. Now I highlighted exposure because I wanted to stress the importance of hiding or protecting your patient from public view. So if you're going to expose a patient, do so in the ambulance. And when you're done exposing them, cover up with a blanket. So use discretion when exposing. Do not cut off all their clothes for a small abrasion. You can always have them take it off if it's not that serious, but use discretion. Secondary assessment. We have vital signs, pulse rate and quality, respiration rate and quality, blood pressure, skin, color, temperature, condition. And always ask medical control if you need assistance or to give any advice. So you're going to give a verbal report to the hospital, and you're always, I started this section here, give a complete patient care report in compliance with state and agency policies. Just a little extra to go with the general approach to patient care. Continuum of awareness, continual situation awareness when going at scene safety. Never get pinned into an area. Medical control may assist if someone has a complex medical condition. This is new for the protocols. We have EMS providers must secure a child to the stretcher. They cannot be held by their parent anymore. And here we start the PCR training, pre-hospital care report. So this is a finished PCR to the right of the slide. This is what all of them should look like. Nice, pretty, filled out all the way. This is by the agency for patient care, pertinent patient information, and tools for transport. And they must comply with Part 800. When to write a PCR? Let's just go with the default. Anytime is a good time to write a PCR. Anytime you get called, anytime you hear something over the radio, anytime you just sit with a bus somewhere, write a PCR. Ask an officer or OIC or crew chief, qualified crew chief, if you have any questions. Information. You can use a black ballpoint pen. This is to make sure that it goes all the way down to the last carbon copy. Who can write on the PCR? Ultimately, the crew chief is responsible. So they're responsible for patient care and patient documentation. They can delegate the writing of the PCR, but ultimately they will be held accountable for any miswriting of a PCR. So keep that in mind. The pink copy, the last copy goes to the hospital. The yellow copy goes to us, and as well as the white copy. So you're only going to tear off that last pink copy. So another thing with the pink copy, the hospital will give you these stickers that designate the patient. Peel off one of those bad boys, slap it on the back of the PCR. That helps them with the patient. Leave it face down in the pre-hospital care report PCR box next to the charge nurse, and go on your merry way. Make sure you always fill out the run number beforehand, before turning it in, and before putting everything away. So this is just a little add-on, patient care report face down, so it doesn't be introduced to the rest of the world. Close the header. Just everyone can read, so they understand what most of it is. But the run number is something we're going to stress a lot. We will find you if you don't fill it out. The run number is filled out year, month, and the number of calls in that month. So let's say it's the third call of the month. Let's say it would be 200803. And here's an example. Please pause the video if you need time to look at this. I'm not going to go too into detail. Just remember, you'll put the date, the run number, and then the disposition, be that a transport or an RMA. So here is an example of what every PCR should look like with your specific mileages, dispatch information, and call numbers. But everything on the top should be filled out. Here's what the driver sees. So You can use the vigilant bus radio to call in the 21s, 22s, the keys, the buses, a push start, so you can just leave the keys in there. The EMS radio down below it, bus loudspeaker, and then those books down below the EMS repeater is the mileage and run log number. Mileage and run number logs. So keep those up to date. Keep those up to date. I can't stress that enough. We're really focusing on the documentation for this year. Call times. Whenever you get one of the calls, write down a time. All of these should be filled out as well. So this is just patient information, name, date of birth, age, social security number. Fill it in as such. Where the call took place, be that an emergency, non-emergency, standby. Typically, we're going to have emergencies 9As or standbys, PKTs. And where'd you find them? Did you find them residential, in their dorm, in their barracks, recreational, tomb field, road, on the road? The body of the PCR. We have our physician, Dr. Ronald Feinstein. We have care in progress. I just put a citizen, bubble that in for an example, but put the name of the citizen. That's very important for legal reasons. Just so you can have an actual name to who is giving care to your patient. Physical activity. This is a mechanism of injury example, which I would say causes a lot of midshipmen to call the ambulance. So you complain, usually as per patient. That's subjective assessment. I'll give an example just after this. So, MM1 responds to a 21-year-old male found supine on the pool deck, complaining of 9 out of 10 pain to left leg, approximately 5 minutes prior to EMS arrival. Patient states he was getting out of the pool quickly when his foot slipped and his leg got caught in the ladder. Patient claims to have felt a popping sensation below his knee. Patient in care of lifeguard Sharp prior to EMS arrival. Patient denies any other injuries. So this is the presenting problems. This is what's wrong with the patient. They're having 9 out of 10 pain in their left leg, sharp bruising. They're having a fracture. So you circle fracture and bubble it in. This is a body. This is where sample and your secondary assessment come in handy. We have an allergy to penicillin. We have an other because it doesn't fill the descriptions in the preset medical history boxes. PMH, past medical history, is a left patellar dislocation. Meds include acetaminophen. Secondary assessment says we took vital signs twice, and we noticed that the respirations rate and quality, pulse rate and quality, blood pressures, level of consciousness, GCS, pupils, skin, and status. Remember status. Cups. C, critical. U, unstable. P, potentially unstable. S, stable. So in this case, as an example, we'll say the patient went into shock due to the pain, and their GCS dropped 1 point. So we broke up. After it goes from 15 to less than 15, you break it up into the three different categories. E, V, and M. That's eye, movement, verbal, and motor. And if you look at the back of the PCR, it has it broken down for the GCS scale. So in this, we have the objective assessment and the comment section. This is where you're going to do your primary assessment and secondary assessment and any other information to report. So just to explain DCAP BTLS, this is a great tool when describing pain or narrowing down what your patient is presenting with. D, deformities, C, contusions, A, abrasions, P, punctures, B, burns, T, tenderness, L, lacerations, and S, swelling. So this is a sample of an objective assessment. Patient is ANO ×4, positive airway open and patent. Positive lung sounds clear, positive and equal bilateral chest rise. Positive radial pulses strong and regular. negative difficulty breathing, positive circulation, motor, and sensor. So they have pulse, motor, sensory in all 4 limbs. Positive C-spine clear, no pain upon palpation or spontaneous movement. Negative jugular vein distension, negative tracheal deviation, negative loss of consciousness, negative dizziness, negative nausea, positive pupils equal and reactive to light, positive lightheadedness, positive bleeding, oozing from 2-inch superficial laceration on anterior lower left leg, positive obvious deformity, positive swelling to lower tibia, positive tenderness, left tibia, positive tenderness and pain upon palpation as per patient, positive crepitus. In MM1, patient condition changed, cool, pale, and diaphoretic. O2 administered at 12 liters per minute with non-revealer vital signs monitored. So this is your primary assessment. This is your A, B, C. You notice airway, breathing, lung sounds, C, circulation, radial pulses. And you just go into detail about the injury. For the comment section, we have the lifeguard manual stabilizing the patient's leg upon arrival. EMS directed Sharp to maintain stabilization while bleeding was controlled with sterile 4x4 gauze pad and 4-inch cling pressure dressing. Lower left leg immobilized with splint and cravats with CMS pulse motor sensory after ×4 after application. So you're going to check that after you apply the splint. Pullback supplied, patient moved to ambulance on stretcher. Seated in a position of comfort, patient transported without further incident. So this is to do with the treatment and the transfer of the patient. So these are bubbles you'll fill in for your treatment. We have moved on stretcher, head elevated, position of comfort, oxygen administrated, limb immobilized with longboard splint, and cold packs. POC is position of comfort. So this is your disposition. North Shore Manhasset is 705, and just as an example, RMA is 005. If you transfer care to Vigilant, it is 004. All those numbers are on the back of the PCR. And fill in the name. The crew chief will be in charge. The name here. Bubble an EMT with your EMT number, and all the other people will have their name and EMT numbers in the boxes to follow. So let's say they refuse medical assessment or the hospital signs oath. So this is your signatures. In this case, they RMA. You're going to have the signature of the patient where it says patient sig, and you have a witness sign. Explain to them in slides prior the consequences of refusing medical assistance, and make sure they know to call back if they ever need any assistance in the future. And this one is an example of a transfer to North Shore University Hospital. So the nurse or physician is going to sign that hospital receiving agent signature up there, where it's circled and started. Is a review of RMA. Please pause the video if you need a review. And please pause the video if you need a review of what to tell the patient if they decide to refuse medical assistance. So for standbys, this is famous 007. Fill out a PCR for every standby, even if there's no patient. And like I said earlier, if you transfer to another agency, be that ALS or a non-midshipman, use the disposition code 004. This is an example of the, just if anyone hasn't been to North Shore yet in a little while, then you enter through entrance number 2, park the bus, back it in, exfil the patient. The driver will repark over here and wait until the EMS providers are transferred to the patient. This is just to make it a little more simple flow of traffic. Okay guys, if you have any questions, please email me or the other officers, and stay safe, save lives. Have a good week guys.